So at CAMI, we are discussing the deployment of MRD to discontinue therapy in multiple myeloma. We all in the field know very well that MRD, as assessed after initial therapy, is a very powerful tool to predict long-term outcome. However, our therapies have, in general, been designed as fixed duration therapy with a certain duration of induction, transition to maintenance that continues until really progression or intolerance. I think one of the very desired next developments in myeloma is to be able to use this dynamic prognostic information that MRD gives us and repurpose that to make treatment decisions on the patients. Maintenance therapy has certainly been one of the greatest accomplishment of the last decade in multiple myeloma care. It has been shown to prolong progression-free survival and also to prolong survival. However, we need to understand that the data for maintenance was generated at a time where regimens used initially were somewhat inferior than they are today. Therefore, it's possible that are some patients that, when treated with more modern and more active regimens, may reach a deep and long enough response that they would not benefit from maintenance therapy. So I think a few things have emerged. One is it's important that we assess MRD at a proper time. It's important that we assess MRD at the proper depth of response. And it's also important that we have consistency of MRD measurement. I mean, there's some concern that one MRD measurement below a certain threshold, for example, 10 to minus 5, might not be sufficient to permanently discontinue therapy. So there are some initiatives that I revealed that are starting to leverage MRD information for treatment discontinuation. One of those in the United States is the SWOG 1803 trial that randomized patients between lenalidomide and daratumumab. And after 2 years of therapy, patients who are MRD negative are randomized to treatment discontinuation or continue on the same regimen they had been on. So that will provide the highest level of evidence about using MRD information to discontinue therapy. On a slightly different approach, the currently planned IFM 2020 trial also uses a very powerful induction regimen with isatuximab, carfilzomib, lenalidomide, and dexamethasone. And patients who are MRD negative after 6 cycles then get randomized to early transplant versus deferred transplant, followed by some consolidation with ISA-KRD. So it's not quite treatment discontinuation, but again, leveraging that dynamic risk assessment that MRD gives us in order to decide on the subsequent therapy. So those are very important trials that we'll be watching for in the years to come. We have our own trial called the MASTER trial that used daratumumab, carfilzomib, lenalidomide, and dexamethasone for induction, followed by transplant, followed by additional cycles of dara-KRD that is time and duration according to the depth of MRD response. So the notion is to continue that intense regimen until you have 2 consecutive MRD reads below 10 to minus 5. Not surprisingly, such a strong combination leads to a very high rates of CR that are close to 90%. But most importantly, what we're learning from that study is that the majority of the myeloma patients, including several high-risk patients, will reach those milestones of having 2 consecutive MRD negative reads. And those patients are currently being observed with a follow-up that is now approaching 2 years. We are noticing the majority of patients reach those criteria, and so far, none of those patients have had either resurgence of MRD or have had clinical relapse. Of course, I think would be overly ambitious to think that will remain the case indefinitely. I think eventually we're going to learn a few things about the pattern of MRD resurgence and a pattern of relapse. But that is certainly very instructive to be able to observe those patients without any therapy, without dealing with the toxicity or the cost of maintenance therapy, having a more robust immune reconstitution, and do well for months and years without any therapy. And I think on the same token, MRD can be or is being instrumentalized to now be a surveillance for a resurgence of disease that is likely to be far more sensitive than the serum-based methods that we currently use.